We are part of the Royal College of Psychiatrists, and we are pleased to welcome you here today to talk about our Advancing Mental Health Equity Collaborative and the launch of our third wave of that programme. It's open, I think, from now for registration, and we are wanting to. We've got this session today to give people a bit more information about what the programme is, why we have it, what joining it means, and also hearing a little bit about people's experience on the programme so far. We have got a few people are going to speak, and then we've got time for questions and answers after that. And we're also going to record the session so that we can put it on our website. If there's anyone who, for any reason, doesn't want to be on they maybe ask a question, you don't want it to be on the internet, let us know and we can edit that out. And I suggest, if you don't want your video to be on the internet, to turn your camera off. Otherwise, please leave your camera on so we can see you. That's nice. And also but have your microphone off during when you're not speaking, just so we don't get the background noise. So I think the first thing I'm going to do is hand over to our president of the Royal College, Lade Smith. Lade was previously clinical director of the National Collaboration Centre for Mental Health and one of the originators of Advancing Mental Health Equity, previously known as Advancing Mental Health Equality. In fact, I think the whole thing was her idea. So I'm going to pass over to her now, and she's going to say a little bit about why it's important and what it is.
All right, welcome everyone, and thank you, Tom. So I'm not going to go into me a bit other than to say this, that we realised some years ago that there were a whole group of people who were getting really good healthcare, but there were other people who weren't. And we spend a lot of our time in healthcare, full stop, not just in the NHS, but across the whole of healthcare, bothering about quality and safety of care. And when we looked at it, it looked like you were much more likely to get good care if you were from a mainstream group. But if you were from a more marginalised group, then actually you weren't getting access to the care. When you did get access, your experience wasn't so good. And ultimately, your outcomes weren't very good either. And there were so many different people from different marginalised communities that actually, overall, it was dragging down the quality of the care that was being delivered. There's no point giving good quality care to only 50% of the population that you look after. And we started to realise that what we were doing was essentially we've designed our services to only look after those who are wellest and are most able to take up the service. And we haven't really thought about everybody else. So essentially, what we started thinking about was how we could make things better for everybody else who wasn't quite getting the same service. And so Advancing Mental Health Equality at that time was born. And I have to say, it was a few years ago. And of course, over time, and this is something that you will learn as well, if you don't already know it, but you start to learn and develop and understand things differently. And at the time, years ago, we were all thinking about equality and everybody getting the same thing. And now we realise actually you need to have different approaches depending on the needs of that individual. This is much more about equity, so that people with different needs eventually will have the same kind of outcomes. And we used to think of this as being a nice thing to do, but actually it's not just clinically important, it's not simply ethically and morally important, but frankly, it will result in better outcomes. And that ultimately is going to be economically cheaper and more viable. It's just more viable. It's a bit of a no-brainer really financially, because if you're not looking after people, they end up coming in crisis, and they come in, and when they do get better, they leave and then they come back again. So getting it right, we want to get it right first time, obviously, but we want to, and to do that, we have to design the services with the most marginalised in mind. If we design the services that work for our marginalised populations, then it follows for everybody else. And that is what the AMHE approach is about. It's about, first of all, recognising who your population are and actually actively going out and finding out who they are. Because if you're going to wait for them to come to you, they're only going to come to you when they are in extremis. It's too late. And then at that point, we have to do things to them that they're not so keen on. Once you've worked out who your population are, then you go and work with them actually, and you find out what they want and what they need. And once you've done that, then you're able to say, actually, we're going to design a service around your needs, and then you evaluate it. It's as simple as that. It's the same. Some of you will be working in areas that have taken on, you'll have heard about the patient care race equality framework, and you might say, what's the difference? Well, actually, these are branches of the PCREF and AMHE are branches of the same tree. They've got the same roots. And so what that means is that if you're doing PCREF already, then actually AMHE will be easier for you because you've already started working with your local population. And if you haven't done PCREF, well, AMHE will help you to start taking on board PCREF. So don't worry that it's one or the other, because they are very, very interconnected. Fine, I'm just going to say my final thing to say to you is this. At first, it might seem hard, but essentially what we're talking about is good healthcare. This is about getting to know your local population, developing relationships with people, and then providing them with care that you want to give, that they want. And in that case, it not only does it benefit the individuals, it benefits the staff who are looking after people, and it also benefits our organisations and our communities. Thank you.
Thanks so much for that, Lade. As always, beautifully put. So in a few minutes, we're going to hear from Emily, head of QI, and Amrit, who's one of the race and equity leads in the college, about what the offer is and what people would sign up for if they sign up for AMHE. But before that, we're going to hear from Steve Budd. Steve is a lived experience expert in the Avon and Wiltshire dual diagnosis team, and that team have been on the AMHE Collaborative for the last couple of years. And Steve's going to talk a little bit about his experience in that team on the programme. So Steve, I'll hand over to you now.
Hi everyone, thank you very much for that. The challenge for me today is obviously, one, my nerves, but two, to somehow condense what's been a 2-year project into 5 minutes. So I'm very closely clock watching, and I have the ability to talk very fast and kind of digress, but I've written it all down, so I'm going to stay on track, guys. AMHE came into my world when there was a shout out email trail asking for people to join a dual diagnosis project. That was chosen by my co-lead on this project, Emma Griffiths, who's a psychologist in our specialised services for Avon and Wiltshire Mental Health Partnership. Geography wise, folks, that is from Wiltshire, Swindon, Bath, Bristol, and over to me, Weston-super-Mare. My job title is North Somerset Service User Care Involvement Coordinator. And I put my hand up and said, yes, I'll join this dual diagnosis. 2 reasons. Weston-super-Mare is world renowned for rehabs thanks to Broadway Lodge, and we have a very high level of rehabs per head of population. It's second only to Bournemouth for rehabs and associated dry houses, etc. with that. When I worked at the council for 5 years as a housing enforcement officer, I was part of something called Operation Jupiter, which is where myself and a plainclothes police officer would visit all the worst houses in multiple occupation in Weston, where we were getting the 999 calls and antisocial behaviour, and time again, drugs and drinks, smackies and crackies were always part and parcel of that poor housing environment. I then got this job 10 years ago, 10 years this year in July, only a year after discharge from a 3-month section for bipolar mania on Juniper Ward in Weston-super-Mare, where I currently work. And part of that journey also began 25 years ago when I was arrested by the riot squad, kettled and handcuffed in my kitchen in the house that I'm sitting in now, and taken to Barrow Mental Hospital just outside Bristol, where my first psychotic episode stayed for 3-6 months. But underlying that, and something that I'm still working with today, is it was not bipolar, it was drug-induced psychosis. Because 25 years ago, skunkweed turned up in my life and lots of other people's life in Bristol, and I embarked upon the Bristol Somerset diet of skunkweed and strong scrumpy cider, skunk and cider psychosis. And I watched various associates of mine go down with that combination, because skunk is quadruples another drug compared to a bit of black hash, which I've been smoking in my student years but never inhaling, of course. And that drove me mad, for sure. But as I say, I have been admitted to Juniper Ward 3 times since then with a diagnosis of bipolar and schizoaffective disorder. So I have to accept that there might be some truth to it. So when this came up, I've actually, in my management, been abstinent through Alcoholics Anonymous and have engaged in smart recovery, self-management recovery technique, and still engage in face-to-face meetings to support my recovery. So I know the two major routes how to manage your drinking. And so I put my hand up and said, yeah, I'll do it. And 2 years later, here I am, stood in front of a very impressive audience compared to sort of where I've been gathering my market research on this project, which is sort of very much at the lower orders of society, unfortunately, because that's where drugs and drink will take you eventually until you hit your own rock bottom. So briefly on this, because I'm already burning up my time, we did a data suite. There's nothing out there on dual diagnosis. We couldn't find it. We managed it. We then put together a survey monkey with a series of questions. What's good, what's bad, what would you change? And don't spend any more money. Out of that, we got about 40 staff to respond across our trust. That was also our third sector supporters on substance misuse, because AWP generally doesn't support the service. We have With You in North Somerset, we have DHI in Bristol, Turning Point in Swindon, etc. There's always a separate service. And so joining those teams together is very important. We got 40 staff inputted into this and about 3 service users. Co-production on this project, because of my involvement, has been about 50-50 to lived experience to professionals in this whole thing. I was very wary about survey monkeys. Post-COVID, I was asked for an awful lot of service user surveys about the impact, etc. And we all got survey fatigue. What does it matter? Why am I telling my story? It's got to change nothing. This survey gave me the clout to say, no, this is the Royal College of Psychiatry behind this. This might change something. Will you help me? And then the next thing I did, I put a shout out and said, look, just send me name and a phone number and I'll phone them. And I phoned 15 people individually, including 5 carers, and said, what's good, what's bad, and what would you change? And we got up to 17 feedbacks from me picking up the telephone, which no one does anymore, but old school. I'm a bit old school. I'm 58 with a white beard. So I phoned people, had a chat, and we got 17 responses, including carers, and some really good feedback from the carers whose sons, daughters, whatever, saying, he told me that AWP weren't helping him. But when I got into his flat and started opening his post, I found 6 letters from AWP saying he hadn't turned up. If they told me, I would have picked him up and dragged him there. But no one included mum in the equation, in that trail of why they don't engage with services. Time's running out. Flying through. I also run a patient Juniper community meeting every Wednesday on the same ward that I've been a patient in, have done for 10 years. I've been running this project by people. Very simple question. Who here thinks that drugs or drink has had an impact on their mental health? Hands up. 7 people this Wednesday, just done it. Do it every week. 7 people. Okay, who would you turn to if you wanted some help with that? Well, I've used With You, I've used and I've been running that face to face. And also at the same time, a very simple intervention is this paper leaflet that I have designed, which explains the difference between the 12-step approach and smart CBT recovery approach, because everyone says you have to believe in God to do AA, don't you? And I go, no, you don't. But most people don't know. So moving forward, what we've kind of come with our driver diagram, the stuff that was coming up was ping pong, back and forth. Got to stop drinking before we'll deal with you. Can't sort your madness out until you sort your drinking out. Ping pong. That came up. The other thing that came up a lot was trauma. I drink because of the bad things that have happened to me. But there's a 2-year waiting list of psychological therapies in North Somerset, so we can't sort your trauma out. Well, I'm going to keep drinking then, etc. That came up. Some of the solutions that we're looking at and I'm working with is reciprocal training with you, where we take our staff, AWP, mental health, into substance misuse and co-work, co-train. We're working on a 3-hour half-day training because it's so difficult to get into staff's time and calendars, and dual diagnosis is not compulsory, etc. And we're working with Broadway Lodge, which is 50 years of 12-step rehab in Weston. That's why we've got so many rehabs in Weston, by the way, is because all the senior counsellors at Broadway Lodge realised how much money you could make out of rehab, rented some grotty Victorian B&B and turned it into a rehab. And you don't have to have a licence to have a dry house or a rehab. You just put a sign up. and off you go. That's another story. What we're seeing as good practice is something that's arrived as a result of the community mental health framework. It's called the MINT team. The acronym is a multidisciplinary community team of 11 staff, psychologists, psychiatrists, housing officer, GP, substance misuse, wraparound service. The next thing that we're looking at, I see Marta here as my guest, is another lived experience person project. Shout out to Marta. There you go. She didn't want to speak today. She's nervous. She said, Steve, you can do it. I said, Marta, I've got to make sure I say everything that we've agreed. So she's going to be checking in on me to make sure that I didn't talk too much and I've said it right, Marta. Okay. Time 48, 46. So what we're doing, training. I've also mapped the pathway. So we're looking at touchstone points at that. We're going to start handing this leaflet out on Juniper ward at my meetings. We're going to start handing it out with the hospital liaison alcohol nurse in the medical ward, in the gastroenteritis, where the heart attacks. Or that's a good point to connect with someone when they've nearly died. Don't you think you want to do something about your drinking now? I think you should. So we're going to start working with you on that. Myself and Marta have a meeting with our MINT team about taking what is a Bristol MOTE group moving on after trauma, which is 4-6 weeks. Very simple format, coffee and chats, group therapy, etc. Bringing that into North Somerset, low cost, easy action. We're also got an AWP, something called the DBT Light service now, dialectic behavior therapy, a 3-month course, 6 o'clock to 8 o'clock, running 2 courses a week, 300 people on the waiting list. I've got a constant referral of people want to share their lived experience co-production. I always ask them, have you had an issue with your drugs or your drink? Who would you turn to help? And I'll get that feedback as well from that group of people.
Steve.
Steve,
sorry. So I think probably we could all. You said you could talk. I think we could all listen to you for another 45 minutes. But I think that was a beautiful taking us through actually the process of doing this work, which is about understanding the need on the ground by talking to people within the populations affected, and then sort of aligning to that the actually what are the ideas that we're going to do, what are we going to test, and what are we going to try to do differently to meet that need. And that's the essence of AMHE, which I think you've kind of taken us through in an amazing style. And so yeah, I hope that gives people a flavour of what the work is. I'm going to hand to Emily now. Emily's our head of quality improvement, and she's going to talk a bit about how we structure that, how we help people to take people through that process that Steve's just demonstrated. So I'm going to hand over to you now, Emily.
Brilliant, thank you, Tom. I'm going to try and keep up the energy that Steve's brought to the Q&A, but I can't promise anything, but I'm going to give it a go. So myself and Dr. Amrit Sachar, who's our joint presidential lead for race and equity at the college, are going to tell you a little bit about Wave 3 of the AMHE Collaborative. We're changing our approach slightly for Wave 3. So for Wave 1 and Wave 2, we've gone in at sort of quite a high organisational level with the organisations that we've been coaching on Wave 1 and Wave 2. And sometimes that's a bit of a stumbling block for the organisations, is once they've identified a population that they want to improve access, experience or outcomes for, it was a bit of a stalling period sometimes to then find the teams on the ground to do the work and test the change ideas, etc. So we're taking a bit of a different approach for Wave 3 based on our learning of Wave 1 and Wave 2. But a lot of the principles still remain the same, particularly around the co-production element that Steve was talking about, is absolutely key to this work and still remains a key principle. So we're going to talk you through the 3 modules. So our first module is for providers of mental health care and support. So this can be NHS trusts, provider, independent providers, and also voluntary sector organisations as well. And we've worked with many local mind organisations, for example, on our AMHE Wave 1 and Wave 2 collaboratives. So again, we'll provide quality improvement support, this time at a team level. So the team will need to be put forward first with an idea of the population that you want to focus on. And as I mentioned, you know, the approach that Steve mentioned there, speaking with people, with communities, really connecting to what are the barriers to accessing a service, for example, and then thinking of change ideas. And the number of examples there you had, Steve, the different ideas and things that you're trying and testing at the moment is a brilliant example of the momentum that you can get and the potential with the AMHE work. So that's the team level support. And I'm going to hand over to Amrit now to talk to us about the next level of support.
Thank you. So this is the middle management level, so the middle layer of any organisation that people listening will be really aware of, quite often referred to by a specialist systems worker called Barry Oshry, who talks about the torn middle or the stretched middle or the squeezed middle. So people in the middle quite often work vertically. They have their direct reports and their teams, and then they report upwards to their managers. And actually, what we know is, looking at systems work, is that the middle management layer is absolutely vital for connecting across the organisation. So what we do inadvertently in what we call blind systems is get them working only in vertical teams and relationships, so that we lose that ability to connect across the organisation and share joint or shared challenges that they're coming across. So what we've found is that these individuals, or this layer, is absolutely key to connecting the front line of an organisation and the leadership of the organisation. And I'm not sure who's on this call, which parts of the system are on the call, but one of the things that often happens is that you might get a board level decision to implement a great idea, but it gets lost in the middle management section in its translation to the front line, not because anybody's being a bad person, but because middle management's tasked with delivering on certain operational KPIs. So the point of this is to, through one-to-one coaching and action learning sets, to support middle managers within the organisation to learn how to connect across the system and to empower and enable their teams, and to allow to be able to translate equity work into their KPIs, and so get the best of both worlds, basically. And then the section, the third module, is the leadership and board module, which is allowing that it is a kind of less intensive support module, but it's for the board and leadership, helping them to understand the equity work and the quality improvement approach, and helping you to deliver your PCREF through this work. So really it's about being able to support, enable and empower the other two layers of your organisation. So it's allowing the three bits of the organisation, the three layers of the organisation, to connect and do the bits that they're meant to do. Thank you.
Brilliant, thank you, Amrit. And we should say at this point that it's up to organisations which modules to take part in and sign up for. So I think illustration there is the three levels and how they complement each other across an organisation, but there is also the option to sign up to just one or more of one module. So I'm going to whiz through these ones. I think Lade mentioned it at the beginning around sort of improving access, experience and outcomes for patients. And that is really the sort of the cornerstones of the Advancing Mental Health Equity Collaborative. And then these are going to flash up on a screen very quickly. But I think a lot of the principles we have mentioned throughout the Q&A so far have been referenced here. So we'll send around the slides afterwards, and you can also look at them at your leisure as well. So
Can I
for
just
organise,
Can I just, could
Yeah.
you go back just one, sorry. So I guess the key thing is that it's about creating a learning community, and that's underpinned with co-production all the way. But within that, there's a huge package of support around it. So yeah, it's just highlighting that.
good point, thank you, Amrit. And then we also know from our AMHE Wave 1 and Wave 2, you know, we adapt our approach based on where an organisation is at. We know that organisations are at varying stages of their sort of equity journey. So we do adapt our approach based on that, and that's both the quality improvement support that we provide, but then also the additional middle management and board and senior leader level support. And also with the learning community that Amrit just mentioned, at each of those levels of support, the opportunity to share and learn with each other. Those that may be a bit further ahead in their, you know, journey can share with other organisations. So that's something that we really enjoy sort of facilitating as a team. So very briefly, in terms of the requirements to join, so for the quality improvement support, the first stage is identifying a team, and someone to lead that team and sort of coordinate the work. We've got a registration form, and there's a link at the end of this slide deck. But we're also happy to answer any questions as well that you've got. So this is the requirements for the QI support level. And then we've also got the middle management and leadership support. Amrit, I don't know if you wanted to give any particular pointers for organisations to think about when signing up for these two levels.
I think so. The point is that for the middle management, unless you've got a team in the collaborative, then we would say at least 2 to 3 middle managers to sign up per organisation, because the point is supposed to be that you can send middle managers or leadership candidates off to various bits of training that they do on their own. This is about making it implementable within an organisation, and so we don't want one manager to do this, because again it will just reinforce the isolation. So it's about allowing them to be part of a team that can disseminate an approach, and then with the leadership level, it can be 1 or 2. One member can be sufficient, but yeah, we can perhaps go into that a bit more detail. And I think the other bit is that there's going to be a period of time before we launch the kind of face-to-face element, which Emily will talk about in a minute. But in the interim, there'll be a 6-month period where we hope to kind of co-create some of the offer with the teams and organisations that have signed up, so we can make bespoke offers.
Brilliant, thank you, Amrit. So yeah, we've got a sort of a lead-in period between May and September, because we also really want to provide, particularly for the middle management and the board and senior leadership level, a support offer that works for you. So to sort of co-create that with you, how often would you like to meet? In what format? Is that online or in person, for example? So we've got that lead-in time, and during that time for the teams, there'll be a workbook to work through to do some preparatory work ahead of the launch. So what do you already know about the population that you want to focus on? Is there any data that you can start gathering in terms of sort of looking at who are your key stakeholders or assets in the organisation, community, organisations around you? So some preparatory work that we can support you through during the lead up to the launch. So we are going to stop there with our slides and presentations to you, and open up to Q&A, really, to give you an option to ask any questions that you've got for our team.
Thank you, Emily and Amrit and Steve and Lade. So just to summarise, then the big idea is that we develop this approach for advancing mental health equity, which is based on a structured way of understanding the needs of the population and using a QI approach to test ideas to meet those needs better. We know that it's it can work because we've seen those successes on waves 1 and 2 of AMHE, but we also know that it's hard, and we've flexed the offer or changed the offer for wave 3 accordingly so that people can join in more flexible ways, in ways that meet the needs of the organisation, and also building in that 6 months period, which isn't part of the programme, that's sort of in advance so that people can hit the ground running when they actually start, and then we're asking the sign up is for an 18-month programme. So we've rattled through loads of information. We've got about a quarter of an hour left now for Q&A, so does anyone have any questions after all of that? Arlene, thank you for being first.
Really brave. So I suppose, what does the end result look like after all these projects have gone on and have, I suppose, been going on for a while? What would we hope to see in terms of figures or people receiving care? What would the difference, I suppose, what would it look like?
Yeah, so the so with each team, obviously they'll be working on a slightly different thing, because we're working with a different population that team and that organisation select. And what we will work with teams to do is to understand what their aim is really specifically, and then how they're going to measure that aim. So what we would say is that has to be around either a better access to care for that population, better experience of care, or better outcomes, or a combination of all three of those things. But that's what it's about. So the end result really that we're aiming for is that more people are accessing care, if that's the aim, or that when they access care they have a better experience and better outcomes. Now, you obviously need to set that aim according to what can be achieved within the time frame. So over an 18-month period, you might say, well, we want to focus on really trying to increase the number of people coming to a service and test that out and understand their experience a bit, but maybe some of the outcomes might be sort of longer term. So it would depend exactly on the program, but we work with each team to sort of work out those outcomes that they're going for and measure that. Amrit, I'm not sure if you were putting your hand up to just come in with the answer. So I'll go to you before Heather. Yeah, thanks.
Yeah. So thank you. I in addition to that, I suppose the having the middle and leadership layers allows the organisation to have some sustainability and a legacy. So it's not just about the project or just about that team. So the other layers are to support spread and sustainability of the concepts and the principles and the ideas, as well as that particular project with its particular aims.
Thank you. Heather.
Thank you. Actually, that was a helpful response to my question that I was about to ask. So I was going to ask, for example, within our trust, we've noticed that we've got a higher rate of detentions for people from Black ethnicity, but a lower rate of support around our community mental health teams. So, and I think, that pattern is in all of our geographical areas, and we've got 4 CMHTs, 4 divisions of CMHTs and many teams. So really, what size of team are you looking for? And I suppose the sort of linked question to that is, if we're wanting to do that in one area and spread it, do we have to restrict ourselves to one geography, one team, or could the offer be, looking at 2 or 3 teams within a division at a time? It's really about, the size of the teams that you're thinking.
Thanks, Heather. That's a really great question. So I think that we would probably want to discuss that a bit more individually to understand the sort of the parameters around that. My initial, when you started asking the question, I was thinking, well, I think the initial, you would work with one, probably test some things out with one team and learn what works with that team, and then with perhaps thinking about bringing the middle management in, particularly think about how that work then spreads across the other teams. To be feasible and doable, if to think about a project which had if there's a common goal between 3 teams across different localities, between thinking about testing different things in those different localities, and there you could more quickly start to learn what are the things that can make a difference and be spread across. So I think the options there to do either of those things, and would certainly be really pleased to talk to you about how that best fits. And I think one of the things we've learned from AMHE particularly is that we need to be really flexible in how we offer support, because the context differs such a lot throughout the country, and working with different populations. So we're thinking about this, it was really around, actually this is the model. Now we're very much around these are the principles and the framework, but we want to work really flexibly with organisations to help them, not enforce a model on them. Does that help?
Yeah, really helpful. Thank you.
No worries, thanks. Steve, come on in.
Could I just respond to what success looks like? Because we've had to do this because it's QI, and we're being QI not only by the college but also by AWP. We had to look at some measurable goals. One of the simplest is that currently our alcohol liaison nurse receives about 10 a week through the medical hospital, but only 1 or 2 through AWP. So with the leaflet and the training, that's what we're going to start measuring over the next couple of years. How many more referrals come into our substance use service, which is averaging 10. Well, can we get that to 22? The next thing that I've been telling my service users about this is this might actually translate through to change. It's a slow burn, but if we make recommendations for better practice and we can get this into the nice guidelines with the support of the college behind it, we might see something change in Weston-super-Mare, which matters to you and me, because there is this survey fatigue of why am I taking part in this, because it seems so out there that my life, my very small world of my drugs and my drink and staying alive, is going to be impacted by chatting to Steve, who's going up to London every so often.
That's really great. Thank you, Steve. Yeah, and just to think about different types of outcomes as well. So we had, one project where they were able through this process to work to demonstrate the demand and need to set up a clinic, to set up a refugee clinic, and that actually is pretty busy now, and they've managed to get through this process sustainable funding for that as well through their commissioners, and the experience and the outcomes look pretty promising for people coming to those clinics. So there are different types of outcomes really depending on the population we're working with. Lade.
I was just going to say actually that the other thing to bear in mind is that this has only been going for a short period of time, and one of the biggest and I say this because I think about what's happened with some of the PCREF sites, and as I said before, it's very much kind of similar, branches of the same tree. And one of the things that we're starting to see is better relationships with the community. And that's one of those kind of intangibles that's really hard to measure. But the expectation, if you've got a better relationship, it means that there are fewer barriers to you talking to people. And that means there are fewer barriers to you accessing a service. There are fewer barriers to you coming earlier, hopefully. So that's, and that hopefully means that in the longer term, it will be fewer people turning up in extremis and having to come back again and again and again. But these are things that we can't yet see. But, the actual kind of harder outcomes, but certainly the more intangible things about improvements in relationships, we're starting to see that. And that is a really good thing.
Thanks, Lade. Just got a couple of minutes left. If there are any more questions. So, Heather again.
Yeah, just what's the success rate in terms of organisations going all the way through the course and, really continuing to engage with it in a really robust and meaningful way?
Yeah, it's a good question. So, it's been hard for organisations. We started right in the middle of the pandemic as well, which was not the ideal context to start this work. And we have had, if you think about percentages, probably like 10 or 15% of organisations who sort of dropped off the work and said, actually, we can't take it forward for whatever reason. I would say of the ones remaining, all have made some progress, but the extent of that it does vary, because some of the problems people are trying to tackle are really kind of wicked and hard. It's difficult to give us a sort of a percentage success rate, if I'm honest, but I don't know, Emily, if you would be able to comment on. Sorry, I put you on the spot with that.
No, that's all right. I can't put a number to it, but I'd say that part of the reason that we're changing our approach is to try and overcome some of the challenges that the organisations have faced. So, for example, and I think I mentioned it very briefly earlier, but we went in a sort of an organisational level, and we worked with people to identify populations that they wanted to focus on. But then the stalling part was then, well, which frontline team, for example, are we going to include in this work? So then it's getting a team on board to do it, finding a team that's got capacity when everyone's extremely stretched. So we're trying to, I guess, eliminate that step and change our approach a little bit, so that when an organisation signs up, if they want a team to take part, they think first about the team to put forward, and if there's a group in their population that they know is underserved, and that could be the focus of their AMHE project. So I think that's sort of the rationale really for changing the approach, because we know there's so much potential with the work and using the quality improvement approach, but we also know the barriers that a lot of our teams have faced. But really want to build on Lade's point as well around the relationships that have been built through this work within the organisations of the voluntary sector. Steve mentioned earlier that he's been able to involve others in this work that ordinarily wouldn't be able to get involved from a lived experience perspective. And so there's a lot of things that can't necessarily be quantified very easily about the benefits of the AMHE work.
What I would say as well is an answer, and I don't know how people will find this, but when we started AMHE, we had something of a pure approach to understanding the your population, and we tried to work with trusts initially for all organisations that weren't all trusts, but organisations to think about all of their population and what they knew about that, and then using a kind of a fairly pure data and co-production approach to try and understand where the needs are, and then do work there. And I think actually organisations got stuck in that, actually, because we're data poor in this area very often. And as Emily said, what our thinking is here is actually often people know who are the underserved populations in their organisation. So let's just come where the energy is now to do something about that and start the work immediately with that, and we think that'll help. The other thing I'd say is we've run a number of quality improvement collaboratives over the last sort of 6 years, and we've had many learning sets and events where people come and present their work. I think that the fairly consistently, the presentations of people's work on this collaborative at those learning sessions has had the biggest emotional impact to the people on those, both doing the work and the people attending those sessions. I think there's a real, people are really doing work that really feels like it's making a difference, and it's sort of hitting the values of what they're trying to do. And probably I'd say that is happening in a way more consistently on it than on other collaboratives. So it's not a number measurement thing, but I think there's been more tears at AMHE learning sets than any of our other ones, and whether that's a good thing or a bad thing, I think in this case it's probably a good thing, and it shows that there's something happening.
I'd also like to celebrate the laughs, if I could. We had a great laugh up in London and took a fantastic photo of us in front of the sign going, look, we're all in London, doing jazz hands, because we were all very excited. So I just want to add that into the mix as well. Look, Marta's smiling, because when we all did jazz hands, I think it was Emily said, would you like us to take a serious one that you can put in the staff newsletter? And we all went, no, that's exactly what we want. We're having a great time up in London. So there you go.
Probably is a good place to a good point and a good place to finish, because actually this work is hard, it's meaningful, but done right, it's also fun. And that is actually an important thing about quality improvement. So listen, thank you everyone for joining. We hope that was useful. There's loads more information on the website, which has gone live now, and we've put it in the chat there. There's an email address on there to contact us, and we'd love to stay in conversation, and hopefully some of you join up with the collaborative. So, oh, Heather, one more.
Yeah, Tom, I just wanted to check if your summary slides are going to be on the website, because they'd be quite useful.
Yes. Yeah.
They are brilliant.
Yep.
Lovely.
Okay. Thank you very much, everyone. We'll see you soon, hopefully.
Thanks, everyone.
Bye.
Thank you.
Bye.
Cheers. Take care.